hospitals, and so many challenges. And also, like when we talk about public health, often it also leaves out the marginalized section. As we heard from Professor George this morning, most of the laborers from rural area, they actually move to the cities for better job opportunities and things like that. But from our own ground experience, we do see that people who come to the city with great hopes and dreams, and often they do face many challenges, particularly in terms of access to quality healthcare, access to education. And people who come to the city and who are in the heart of the city, they are forcibly evicted and relocated to the peripherals of the city. And in the peripheries, most often they do lack access to quality healthcare. In our experience, we have come across where women, for lack of PHCs, urban primary healthcare centers, in the relocation centers, by the time they could reach the hospitals, I mean, she has delivered on the road. And people who had a heart attack, they've died for not able to access. And there are many challenges. We also know that people, for lack of access to vaccination, they also had many challenges. People who were in the emergency during COVID time, as they were waiting, also many actually they died, and so many stories we do have from our own experience. And of course, many Dalit hamlets, Dalit colonies, tribal hamlets who have been left out of access to quality healthcare as well as vaccination. So, and this session actually, we are looking at public health and governance. And it is not that citizens are mere beneficiaries of being at the receiving hand. Rather, they have to be they have to be co-governors, like how actively they could participate in the governance process, so that access to health, quality healthcare is actually made available to everyone in our society. In fact, like the recent economic survey also highlights so many factors, like how citizens can actively participate in the governance process, so that public health, they can actually design their own thing. In fact, we needn't depend only on the government hospitals for access. Like, for example, very good example from the state of Tamil Nadu. If someone meets with an accident, within 24 hours, they can immediately go and get the treatment from the nearby any hospital, any private hospital. The entire cost will be borne by the government of Tamil Nadu. So such progressive things, no, we have to be a co-creators. Like, we need to design together, be active part of the governance processes. Often citizens think that when it comes to governance process, it is not my cup of tea. Like, I don't have much role to play. So, and this sessions, like, we have two eminent persons, Dr. Alex George. May I now request you to come to the dais, please, Alex? And we have Dr. Jayashree. Could I request you to come to the dais, please? A brief intro about both the speakers. Dr. Jayashree, she is an author and an acclaimed medical practitioner. She has worked for rights of women, transgender community, people with mental illness, sex workers, through non-government organizations since 1985. And she has also published around 40 articles in academic journals. And she also writes in popular magazines, and she has published 3 books. Erukon is a recent publication gaining critical acclaim. And she also has her own website where she has actually posted the articles that she has published. Welcome, Dr. Jayashree. Okay. I also would like to please give a big applause. Thank you. Yeah. Also would like to introduce Dr. Alex George. He's a Kerala-based researcher and writer from Adur, whose work actually spans from social research, environmental issues, and development policy. He holds a PhD in sociology from University of Bombay with a focus on Kerala's Dalit movement and a MA from Loyola College of Social Sciences, Trivandrum. Over 2 decades career, he has worked extensively in the health sector, serving in leadership roles at the Institute of Health Systems, Hyderabad, and the Center for Health and Social Sector Studies, Secunderabad. He also led child rights programming at ActionAid India. He is our colleague, ex-colleague, and once an ActionAider, forever is an ActionAider. And his writing appears in publications such as Hindu, Frontline, EPW, and varied seminars and Down to Earth, where he has published a notable field study on Kerala floods also. And given after, like, no, in 2018, when during the Kerala floods, he has extensively supported and led our entire relief and rehab work in Kerala. Also, he has done multiple impact study on capturing the outcome of our intervention across Kerala, Tamil Nadu, and various other states. And his research actually interests include Dalit movements, public health equity, child rights, water resource management, and development policy, with collaborations spanning with organizations like ILO, UNDP, Ford Foundations, and DFID. Without taking much time, I would like to now invite Dr. Alex George to please present your presentation. Thank you.
Presentation has a few strands like population, urban population in general, slums, and their public health and it's okay, it's going well. Whatever. Okay. Yeah. It's setting up the presentation, it seems. And the condition of the slum population nationally, and I mean, with its public health implications. Yeah. And the various policies that urban health, through which urban health program has developed in India. Yeah. So I mentioned about the population part of it. Mostly you will know these statistics already. So I'm only mentioning the last part of it. That is the, according to the 2026 estimate, there are 555 million people in India. That is 37% of the population living in urban areas. And it has been pointed out by various of authors that there is a substantial ongoing influx of population into the urban areas, particularly in the slums with nondescript and also other decrepit slum-like habitations with poor access to basic facilities such as safe water, drainage, sanitation, electricity, cooking fuel, paka houses, and public transport. All these have various implications for health, as you know. And public health criteria actually is implicit in the very definition of slums. I am just using one definition, which was used by the National Sample Survey 69th round, which was done in 2012. It was particularly on the slums. So it defines the slum in this manner. Any compact settlement with a collection of poorly built tenements, mostly temporary nature, crowded together, usually with inadequate sanitary and drinking water facilities in unhygienic conditions, was considered a slum by the survey, provided at least 20 houses lived there. So this inadequate sanitary facilities and inadequate drinking water facilities and unhygienic conditions is very much part of a definition of slum, which have all got implications for health. Now, slum population, why we are looking at it is because it is the most excluded of the urban population. And according to one estimate in 2012, again by the 69th round, there were 8.8 million households living in India's slums, out of which 5.6 million were in notified towns and 3.2 million in notified slums and 3.2 million in non-notified slums. Now coming to the census of India, Census of India is actually listing a slightly higher population of 1.37 crore households as slums. These include notified slums, recognized slums, and identified slums. Now coming back again, based on the definition which was mentioned before, what is the drinking water situation in our slums? We have different statistics which is collected from various sources. So the NSS 78th round, that is the multiple indicator survey of the NSS, which was conducted in 2021, it gives 97.2% persons in the urban areas had access to improved sources of drinking water. Now again, let me tell you, there is a limitation. After the 69th round, I could not get any NSS round which is specifically looking at slums. So what we are forced to do is to use the urban data and make some inferences from this urban data of the 78th round. 78th round says that 97.2% of persons in urban areas had access to improved sources of drinking water. And later on, it says 76% of the persons in the urban areas used improved sources of drinking water. Now, having access and using as part of household premises are two things. So, having access means usage is even in the public taps and all. But using within the household premises, you have got only 76.3%. Now, according to the NFHS, which is not making this kind of a very delicate, this kind of a bifurcation, you see that 99% of urban households have had access to improved sources of water. But then in their the gamut of things, public taps are also included. That is why you have a higher 99% which you find there. Now, this is the definition for improved sources of drinking water according to NSHS, which includes piped water, public taps, standpipes, tube wells, boreholes, protected duct wells, springs, rainwater, tanker trucks, cart with small tank, bottled water, and community reverse osmosis plants. So now coming to latrines, part of sanitation, which was again based on the definition which I gave in the beginning. In about it's better that you leave this slide because it is giving some confusing statistics, again because of the kind of data which is available. So there is a more straightforward data from NFHS which is available here. Even though they are talking about a toilet, it is actually about latrine. Now, NFHS 1920 says that 81% of households in urban areas used improved, not shared toilet facilities, while 11% used shared facilities. So it is very straight. It is telling that 81% only were using non-shared latrine facilities. Now, what is improved toilet according to NFHS? It is mentioned here. Including any non-shared toilet of the following types. It is mentioned flush toilets, Piper sewer systems, septic tanks, pit latrines, or an unknown destination, ventilated improved pit, biogas pit latrines, all this. The main thing is it is not shared because of the fact that it is not shared, it prevents contamination. Now coming to another aspect of sanitation.
You speak into the mic, no, Alex?
Looking at my eyes.
Okay. You want a hand mic?
No, it's okay. This is fine.
Yeah.
Yeah. Coming to sewage and drainage, which is another important part of sanitation. We find that 44% of the notified slums and 18% of non-notified slums had underground sewage system. Whereas an estimated 31% of slums, 11% of notified and 45% of non-notified slums had no drainage system. The open Pakka drainage system prevailed in 35% of all slums, 49% of notified and 25% of non-notified slums. So again, I am not getting any more recent data on this after this 2012 round. So because of that, I have to leave it there. I could not take it to more recent data. Then coming to solid waste management. According to the 2012 NSS round, it is mentioned that in 27% of all slums, there was no arrangement for garbage disposal. Absence of garbage disposal in slums was noticeably less in the million-plus cities than in urban areas. The municipality or corporation had arranged for garbage disposal in 62% of all slums, 80% of notified and 49% of non-notified slums. Daily garbage collection was reported by 57% of slums having a garbage disposal arrangement. About 15% reported a once in 2 days frequency of garbage collection. This is again 69th row. Now, more recent data, what we get is that door-to-door collection of municipal solid waste has expanded to 98% of urban wards by 2025-26. Urban wards, not corporations or municipalities, by a fleet of 2.5 lakh waste collection vehicles nationwide. Now, I am not able to corroborate this data with other information. This is from the economic survey, but other corroborative information is not available. Now, coming to the governance part. See, the 74th Constitution Amendment 1992 transferred various subjects to the urban local bodies. Out of the 18 subjects, these are some which have got implications for health. Urban poverty alleviation, which has got, even though it is poverty alleviation, it is very much linked to development of health as well. Water supply for domestic purposes has got implications for health. Then public health and sanitation, conservancy, solid waste management is very much connected. Slum improvement and upgradation, provision of urban amenities and facilities such as parks, etc. Public amenities, in that public conveniences are there. Then vital statistics, which includes registration of births and deaths. Then regulation of slaughterhouses, which has got implication in terms of how the waste from these slaughterhouses and all are kind of handled. Then urban forestry, protection of environment, ecological aspects are coming in that bunch. Then safeguarding of interests of weaker sections of society, including physically handicapped and mentally unsound. But the major omission in this list is that as far as the rural sector is concerned, in the Panchayat Raj Act, public health, hospitals and dispensaries are all supposed to be transferred to you. Not that the transfer has actually taken place in all states. We are all supposed to be transferred to the Panchayat Raj institutions. But in the case of urban institutions, only public health and the public health, sanitation, conservancy, solid waste management, these are the only directly this is the only subject which is directly related to health which has been transferred. Baki all are related, but this is the only one which is directly related to health. And what is straightforward health is not actually transferred to the public health institution, the urban local bodies. Now this lacuna was pointed out by the National Health Policy 2002, which highlights the disparity in health delivery in the urban areas. It says that due to non-uniform organizational structure, unlike a uniform three-tiered structure in rural areas, a meager public health infrastructure in slum areas is also found. It stressed the importance of strengthening public health infrastructure in urban areas, which were more heterogeneous in terms of habitation compared to rural areas. Now, what is meant here is, in the rural areas, you have got a three-tiered structure of a sub-center, a primary health center, and a community health center. Sub-center for 5,000 population, and then above that you have the primary health center for 30,000 population, and then you have the community health centers for 1 lakh population. But here in urban areas, we don't have that kind of a system, and that kind of a system is not also workable in the urban areas, because urban areas, the administrative structure and the population concentration is all very much different compared to the rural areas. Rural areas are largely socially, it has a certain homogeneity, even though caste and class are all involved there. But even apart from that, at least there is a certain level of homogeneity on which health planning is possible. But here it is more administratively and geographically and socially, it is much more disparate. So this table brings you one of the administrative issues with regard to that. You have got statutory towns, which are 4,041 towns, which are the municipalities and the corporations and all. And then you have the census towns, which are not any municipalities or corporations. Then you have urban agglomerations, which are large urban concentrations. And then you have outgrowths, which are not actually urban in administrative terms. They are actually governed by gram panchayats and all. And then you have the million-plus cities, which are very big cities. So this kind of a disparate demographic, social, and geographical and administrative system, which is operational in the urban areas, is making it more difficult for urban health planning. Nevertheless, it is much important as well. And next slide. In 2016, the Ministry of Urban Development asked 28 states to convert 3,785 census towns to statutory towns for better planning and development. But because of the pressure from the real estate lobby, due to increased taxes which will come as a result of this kind of a transfer from a rural panchayat to an urban local body, this conversion has not really taken place to the degree that is expected. Then comes this National Urban Health Mission, which actually started functioning from 2013. Even though the planning for it has started from 2008 onwards, there were a lot of discussions going on till 2013 when it was finalized. The 2013 policy strategy suggests that financial protection for health for the vulnerable urban population in the slums and other urban poor could be achieved through the universal provision of healthcare services from the urban public health center and the urban community health center. The focus of NUHM was primarily on strengthening the healthcare delivery system rather than the insurance model, which was being talked about from 2008 to 2013. So there was a big discussion going on within the government about the insurance model versus the government versus the development of the government health sector model. And finally, they decided that it is better to develop the government health sector rather than rely on the insurance system. And for urban health mission, that was the model which was actually envisaged. So now, then in actually NUHM structure, it is not actually, it is 2023 also, it is the same thing. This is more or less the same structure in 2023 as well. We will come back to that. The Mahila Arogya Samitis for 100 households, Aishas for 2,500 urban poor population for outreach work. Then the urban, yes, there is some problem with that data. Urban primary health center for 50,000 population and urban community health center for 250,000 population. This is what was envisaged. This structure remains the same. There are other changes which has come about in the National Urban Health Implementation Framework of 2023, in which they are talking about, they are saying that there is a low utilization of public health facilities and there is a mushrooming of private providers and their utilization in urban areas, which have led to out-of-pocket expenses notified by this document, noticed by this document. To leverage the existing private providers, it suggests strategic purchasing. Now, what is strategic purchasing? Strategic purchasing clearly means that you will purchase health from the private sector. Now, when you say that, it is one way, it is directly promoting the private sector, and it will also amount to bringing back the insurance system, which was actually given up by the government after 5 years of discussion. So we can expect that the insurance system will come back, because insurance system is the one which mainly works with the private health sector. That is why the term strategic purchasing is introduced for a possible introduction of the insurance-based model. Then regarding the coverage of the NUHM, only 1,213 cities out of the 7,935 towns have been covered by the NUHM, according to the statistics which I am using from Indrani Gupta and A.K. Singh. And they have also brought in a comparison between NRHM versus the NUHM in terms of total health expenditure. They are saying that 17% of the total health expenditure was spent, total central government health expenditure was spent on NRHM, whereas only 0.07% was spent on NUHM. And that was in 1920, and in 2021, for NRHM, 15% of central government total health expenditure was spent, whereas for NUHM, only 0.6% of the total central government health expenditure was spent. It is not that one should not be spending a high amount for NRHM, but there has to be a proportionately high amount for NUHM also, because the urban population is quite substantial, and you have put in place all the policies with regard to that. And one of the more recent reports which have come out is the 15th Finance Commission report, which makes various recommendations, various observations and recommendations in connection with the health sector, particularly how health sector is being managed by the state governments and the urban local bodies. It says, basically I am using the same words. I am not putting it in my words even, because I don't want to be seen as somebody who is promoting something on my own. I am using their own language in this particular case. Many state governments, the 15th Finance Commission is saying, many state governments have not been proactive in transferring functions, functionaries and funds to the local governments as stipulated by the Constitution. Kerala has established itself as an example where local governments and staff of public health institutions effectively deliver health care at the local level in a collaborative framework. Then again, it gives a more detailed description of the Kerala situation. Kerala, how the Kerala's health system is working, the local bodies and the state government, how they are working in a collaborative manner. So the commission is saying, taking a cue from the Kerala model, we consider this to be an opportune time to involve the third tier of the health sector, that is the Panchayat Raj institutions, and to extend additional resources to strengthen primary healthcare at the grassroots level. That way, primary healthcare is also the third tier of the health sector, tertiary, secondary, and primary. We believe that the involvement of local governments would also make the health system accountable to the people. Now, the whole thing is to what extent it is happening. Is it happening all over the states, etc., is a different matter. And we intend to give, the commission again says that we intend to give support for diagnostic infrastructure in sub-centers, primary health centers, and urban primary health centers under the vision of comprehensive primary health care. Then it says that it intends to give additional support to the urban health centers, urban health and wellness centers as well. Then in the next slide, because I have to summarize also, involving Panchayati institutions as supervising agencies in these primary healthcare institutions would strengthen the overall primary healthcare system. We also recommend that representatives of urban local bodies and 3 levels of Panchayat Raj institutions should be involved by entrusting them in a phased manner with the responsibility of supervising and managing the delivery of health services. And here they go into the Kerala system in a more detailed manner. One major reform implemented in Kerala in 1996 was the transfer of 35 to 40% of the state government's development budget to local budgets. But actually in the present budget, it has not reached this level. It is only 28.57% of the budget which has been transferred to the local governments. And this transfer was accompanied by training and granting of autonomy to local governments. Some of the people from ActionAid here who will be knowing that the institution called KILA, where Urban Action School was conducted before, was the main training center for the Panchayat Raj institutions. So if some of you had any opportunity to interact with some of them, I mean, whole hordes of people, elected representatives, various levels of officials from the Panchayat Raj institutions used to come to KILA for training. So we could see them getting the training over there. So this transfer was accompanied by training. And as part of the move towards decentralization, sub-centers and primary health centers in rural areas were brought under the overall supervision of panchayats. Community health centers and taluk hospitals were under the purview of block panchayats, and district hospitals under the district panchayats. CHCs and taluk hospitals in urban areas were transferred to municipalities and municipal corporations. Now, while the total number of posts and sub-centers and PHCs remained under the Kerala state government control, appointment of temporary staff to offset vacancies came under the purview of panchayats and municipalities and corporations. staff working in local governments and state government, and the number of positions and transfers are determined at the state level. So the recruitments, appointments, recruitments and transfers are dealt with at the state level. Whereas if there are any short-term contract-based appointments, they were done by the local bodies. That is the kind of arrangement. And all said and done, it is because of a proper collaboration and cooperation between the state government and the urban local bodies that the Kerala's the decentralization actually worked in Kerala to this extent. It is not straight away handing over everything to the decentralized bodies. There are a lot of other nuances which are also involved. Then, yes, please. Yeah. Yeah, so that is also mentioned. It's not moving. I think the presentation is not working, so I will make an oral presentation and complete. So I have two examples of solid waste management from Kerala and MP. See, Kerala solid waste management, I hope, would have been presented by Dr. Sharada Muralidharan already. But anyway, I will go through that. It is actually implemented by the urban local bodies and panchayats. Composting of biodegradable waste at households, institutions, and community level is the base of it. This is about biodegradable waste. And some 25.8 lakh houses in 2016-17 and 28.86 lakh houses in 2025-26 and 1,574 community level treatment units were functional as late as 2025-26. Then door-to-door collection of inorganic waste from households and institutions by members of the Haritha Karma Sena, their numbers have swelled from 5,000 in 2017 to 37,800 in 2025. Then non-biodegradable waste was collected from households and other sources is temporarily stored in material collection facilities. It's not working. Yeah. Non-biodegradable waste, which is collected by these Haritha Karma Sena people, are stored in these material collection facilities temporarily or in the mini material collection facilities. And then recyclable waste is sent for recycling facilities, while non-recyclable waste is directed to co-processing facilities such as cement plants. And non-recyclable plastic is shredded and is used for making roads. It is purchased by the National Highway Authority also. Then another example of solid waste management from indoor MB. It has got garbage collection vehicles which were repurposed as moving platforms for the Do Bin Har Din campaign, reinforcing the segregation practices. Communication efforts combined with traditional outreach such as Nukkat Nataks and wall paintings were used, radio jingles, social media, and programs to instill segregation norms in school children were used. Road shows were conducted by municipal officials and elected representatives, and it engaged self-help groups, something like the Haritha Karma Sena, in material recovery facilities to spread awareness, and non in material recovery facilities and to spread awareness. So this is a small mention about the indoor model. It has got many things to be talked about, but I am not going into that. Now, going forward, what is to be, a few things are to be thought about. One is to strengthen the urban healthcare delivery in the urban areas, its spread as well as its services, and transferring of urban healthcare in all states to urban local bodies with appropriate integration mechanisms. I like how it is functioning in Kerala. Integration mechanisms for staff recruitment, transfers, infrastructure development, purchases of drugs and consumables, as well as other related matters. Then increase of central allocation for urban health, drinking water, sanitation, solid waste management, focusing on slum population in the cities. Why we are talking about increase in central allocation is because I don't know how many of you know, only 30% of the overall health expenditure in the country is by the central government. 70% is by the state governments. So it is quite appropriate to say that there should be more central spending. Then I'm also suggesting audiovisual documentation of state, city level good practices on decentralized and participatory health delivery, as well as on urban socio-economic determinants of health for not only documentation, but dissemination as well. With this, I conclude. I'm sorry for the disruption in between. And anyway, the presentation is given to all of you, so you can make use of it. Thank you.
Thank you, Alex. I would not like to take much time. However, Alex has highlighted the different data pertaining to health as well as the governance. And one key thing that he has highlighted is that non-recognized slum, which lack actually access to water, health, and things like that, and how it has its own implication for health. And another important factor that he has highlighted is that the importance of integrating like urban governance and public health, how the local government has to be involved in order to so that people also can be active part of this, they can hold the system accountable. And of course, he has said that we have to have this integration method of urban governance and local, urban governance and public health. So with this, we'll move on to the next speaker. May I now invite Dr. Jayashree to make our presentation, please. Yeah. Alex? So good afternoon, everyone.
Okay. My presentation is on our Kerala's experience of local governance and public health in the recent past 10, 15, 20 years. Actually, we have done an evaluation of the program, our decentralization and its impact on health programs in Kerala by an NGO known as Health Action by People. I was also part of that evaluation. My presentation is based on that. So when we okay, look at the history and evolution of Kerala's local governance. We can see that also has happened along with the 74th and 76th constitutional amendment in the mid 90s. And there was very effective implementation in Kerala comparing to other states, I would say. So there was a direct transfer of power and resources to the local governments. And we all know that our three-tier system, this Gram Panchayat, Block Panchayat and Jilla Panchayat, corresponding to that, we have the healthcare institutions like PHCs, CHCs, taluk hospitals, district hospitals, all these come under the three-tier system accordingly. And initially medical colleges also were under the district panchayat, but later it was transferred to the state. And what has happened in Kerala, there is, that in Kerala society is much enlightened through various movements here, which happened long back, like many reform movements, literacy movement, and socialist movements, and all. Because of all these, there was a demand from the people for decentralization even before our decentralization planning of the constitutional amendments. So that we had such a history. So that is important. So what happened as a result of this decentralization is that one is the confluence of elected representatives and the experts. I remember those days when we had all discussion about the decentralized planning in Kerala. We were very skeptical whether the doctors or the healthcare institution authorities will accept the governance by the local panchayat president or somebody. But it has really happened. Now we are working together, the local governance people and the experts like doctors are working together. So the process is that initially we will have a need assessment in the Gram Sabhas, or in case of municipal areas or urban areas, it is the Ward Sabha. So there will be people's participation, and there will be a situation analysis by the experts, and we will have Vikasana Samitis. There is a forum where all these experts come together, political, administrative, professional, and other activists also come together. There will be a Vikasana seminar, and that will lead to the local level planning. So then there is scope for innovation according to the local needs, and definitely more community participation. But what has happened, we know that in urban areas, it happened much later only. All these, I was talking about the rural areas, but now we are moving to the urban areas also. So basically, there were some structural changes. That is what the political leadership is directly transferred the power to the local government. That is what we call it as a big bang approach, because it was a sudden transfer of power in Kerala. But slowly we have accepted it. And the third of the budget is given to the local government, and there is more community participation, definitely, especially the women's participation through Kudumbashri and such neighborhood groups like that. Then now the local government people are visiting the healthcare institutions. They can monitor the healthcare institutions. The visits are happening. Then regarding bottom-up approach, even though that is our idea, I don't know how far we are able to do that. Still, there is some top-to-bottom approach that we have to accept. And considering the access to the healthcare institutions by people of Kerala, we can see that there was a shift to the private institutions. In between, around 7 years back, 70% of our people were accessing private institutions, but after the lot of effort from our government and local governments, the institutions have improved a lot. Now we have some family health centers also, which are the upgraded PSCs. And now again, there is a shift for movement towards or access towards public institutions in Kerala. That is happening. Next. Yeah. So this is a structure of the urban local governments and the health institutions. We know that the governance is through the corporations or municipal councils, but at the same time, part of it is coming from the Jilla Panchayat. The even resources and administration comes from the Jilla Panchayat and Block Panchayat also. Then there are the health institutions, Taluk hospitals, district hospitals, which will be mainly coming under the Block Panchayats or Jilla Panchayats. Then CSC, PSC is coming under the Gram Panchayat. Then we had corporation health clinics before. We had only in the corporations, we had only one doctor before. Whereas now, as a part of the other speaker was also talking about the National Health Urban Mission. After the urban mission, we have urban PSCs. In Kerala, we started it, even the 2014, we started the urban health centers, which are functioning good. So this is the urban health center in urban PSC in our area. So there are 8 to 10 urban PSCs in a district now in Kerala, and there are urban health and wellness centers also. So that is corresponding to the sub-centers. You all know about the sub-centers. So such centers are also in the urban area. The difference is that unlike rural area, there are doctors also in our sub-centers in the urban area in Kerala. Then the programs they are running is mainly nutrition, then screening for diseases, outpatient department in our center. Average 100 patients are coming from the urban area per day. Then there are special clinics for NCDs, that is non-communicable diseases, then psychiatry, optometry. Then all these, our institutions have some palliative care component, again, very special to Kerala. Then our center have got a daycare center for the mentally challenged women, and some of the centers have it for the elderly people. And the financing also is interesting. Usually the funds to the municipal area comes from the municipal corporation, but major part of the finance is coming from the NHM. So funds can be for all these things, equipment, medicine-based management, all these things. For the infrastructure and human resource, it is mainly coming from the NHM, whereas recurring expenditure mainly from the local self-government. That is how it is. Then 2/3 of the social development expenditure is given to the local governments. Now the control and power is for the local self-government, which is again a positive aspects of this decentralization and more transparency, of course. But there are problems. In our evaluation, we have found that only 50% of the fund is utilized, whatever is going to the local governments, and more is spent for human resources and also more for Ayurveda than the modern medicine. So here actually there is an opportunity for collaboration with other agencies, and the other speaker was also talking about it. For example, this is some of the areas this is happening in waste management and water supply. Definitely there is a collaboration with other departments, and some of the institutions are doing this collaboration with private diagnostics to reduce the cost for the poor people in the urban areas. Then collaboration with the block panchayats for dialysis centers. Even the demand for dialysis centers also come from the people. And if the fund is not sufficient for the municipality, they will be collaborating with the block panchayat from where they can access more resources. Then there is integration with the funds like MLA funds, Shuchitwa Mission and agriculture. All these can be collaborated. Then for palliative care. This was some innovative approach in some areas. They were mobilizing resources by their own means, like lottery and local food market, like that. Then sanitation, of course, there is a collaboration with district panchayat. You know that we have a very good sanitation system in Kerala. Maybe some pockets may be exempted, otherwise it is very good. Then the pooled funds, that is how we are managing it. Okay, so these are some of the good examples in Kerala. We all know about the Kudumbashri. There will be always already some presentations on that. Definitely, I know. We have the neighborhood groups like Ayalkootam, ADS, the higher level and CDS, etc. And maximum participation of the Kudumbashri will happen in the Ward Sabhas in the municipal and the urban areas. And there is, of course, participation from the Dalit groups. Then Monday challenge by Asha workers for cleaning is again an innovative program we were having. Then self-employment for the women and the elderly, some of the urban governance is trying. And we all know the COVID time contribution of our neighborhood groups. That is one reason why Kerala has exemplified in during COVID time to showcase it even to the other countries. And this also is another feature in Kerala. Even Asha workers are becoming elected representatives, right? And even Kudumbashri members are becoming elected representatives. Even in our own institution, one of the CSC, Community Health Center, our cook, she was a cook and she has become the elected representative, and now she is governing the institution. That kind of power transfer is changing. And this is another innovative approach known as Santanam that is again facilitated by the NGO Health Action by people. It's a Kudumbashri workers. Some of the Kudumbashri units, they are trained to do the screening for diabetes, hypertension, and cholesterol, etc. And they give home service. They will go to the homes of people and they collect money also for that. So it is like a self-employment for the women, and it will be monitored by the health experts. And Vayomitram also is a Kerala special program by the Kerala Social Security Mission. It is only for the urban areas, and they are appointing a doctor, and doctor and the team will go to the communities, some centers, and they will do the periodic checkup once in a month or twice in a month, like that. And now recently we have started this Well Women Clinics. That's again a Kerala government initiative that is not only in urban and rural areas, all the sub-centers, and in the urban area, that is the wellness center. The health workers will, along with the neighborhood groups, will be organizing the screening camps. They will organize it in some houses, some libraries, or wherever space is available, they will organize it. And there will be expert examination sessions will be there with the doctors. Then there will be referral-based follow-up treatment, awareness programs, etc. It's a very recent Kerala government program. And mainly there are nutrition and sanitation committees. It is both in the rural area and urban area. In the ward level, there is a committee, and also in the municipality level also there are committees. They will be monitoring all the sanitation and nutrition activities. And regarding TB, again, very good example from Kerala. One of the areas in Kerala, tuberculosis is very much related to poverty and undernutrition. They have one panchayat has started giving food to the TB patients, and now it is taken as a national by the national program. So the national program also, now this nutritional program is there, taking the example from Kerala. So there can be collaboration with municipality during pandemic also, collaboration with different agencies. Then good planning in service, that is one municipality people told that they had a very good planning so that they got increment in fund in the fund allocation. That's an example. And then some places there is people's demand for cancer treatment and dialysis. So for dialysis, the fund may not be sufficient, so they will mobilize it from some other areas. Then Dalit colonies also, they had some programs, and what they have found, they have identified some problem like there is seasonal employment as a problem. That is how people are participating in need assessment. Changing. Okay, then palliative care again, Kerala was had the innovative approaches. So palliative care, there is taluk hospitals. Actually, they are having the fund. Funds will come from the block panchayat or the Jilla Panchayat. So they will share these things, all these materials, whatever is required, the materials like crutches, bags, etc., with the municipality or corporation. So that is how they are managing it. They will give home care for the bedridden. Then one area they got some award money, and that money they spend for cancer medicine, because the cancer medicine is very expensive. So the people decided that they will give that money for the cancer care of the people. Then there is tobacco cancer screening that also demand from the community and by Kudumbashri it is done. Harida Karma Sena, all of you know, maybe other presentations also. There is a Harida Kerala program in Kerala. There is a green protocol, again managed by this local governance. And in one area, there is a material recovery facility centers and shredding units. Some of the areas, these innovative approaches are there. Then disposal at source is another innovation. And there was a students' green army. Some reports showed like that. Then community also, we have green volunteers of Kudumbashri. There is very much community participation in these activities. So migrant workers still, it is an unaddressed problem. Even now there is problem with the migrant workers because of their poor living conditions. They are living in very bad situations. They don't have proper accommodation, proper sanitation facilities like that. That's a reality in Kerala. And they don't have health insurance also. And their high mobility is a barrier for accessing treatment. But we are trying to provide services through the camps, screening camps and treatment camps, etc. It's very difficulty in accessing because of timing, etc. Then immunization. I'll finish. 5 minutes again. And immunization also, there are outreach services and treatment of communicable disease. Usually we have malaria cases. Again, it's difficult to treat, and TB, tuberculosis, when they are getting transferred, since it is a national program and we are providing free medicines, it is difficult for follow. Okay, I am ending with some challenges, but a lot of challenges. I was only presenting the positive aspects. We have the challenges. One thing is the rapid urbanization happening in Kerala, and the municipality, the waste problem is less, but in corporation it is more. People are still dumping waste, then shortage of funds in different levels, bureaucratic delay. This bureaucracy is still the previous type of functioning. Then less autonomy for the block panchayats. We have better autonomy and funds for Jilla Panchayat and the Grama Panchayat, but in between block panchayats have less autonomy and less funds. That's a challenge. Then usually there is a tendency to stick on to the previous projects, not for innovation. Then when the functionaries are transferred or retiring, there will be problem. Then there is a field of audit objection. Then elected members, some people favor more for infrastructure, the lack of interdepartmental coordination, lack of convergence of some programs. Yeah, then delay of availability of expensive medicine sometimes we experience. Then people are more active in beneficiary discussion rather than development in general or innovative programs. There will be always a rigidity in the planning guideline. When it is coming from top to bottom, there is rigidity in guideline and priorities. More conflict of interest will be there. Less autonomy and power for urban authority. Then various agencies working together. Then dog menace is a big problem in Kerala. That's the last slide only. So these are some of the issues. There is a lack of sensitivity related to gender issues. For example, one place we have some Jagrada Samitis to address the issue of domestic violence and the problem faced by women. But sometimes the authorities are not sensitized about it. So it is not functioning properly. The women's health is always neglected. There is a lack of toilets in the public places, public toilets. Even though the majority of the panchayat presidents are women, this is something lacking, lack of feeding room. And also there is no demand coming from the women. That is again a lack of community participation. Okay, thank you.
Next to the guys. Thank you, Dr. Jayashree. She has actually started with a very positive note of how the impact of decentralization on health in terms of direct transfer of power and resources to local governments. And also she went on to share Kerala's experience of the various programs, how it's operating in Kerala. However, towards the end, she concluded with a lot of challenges like other states also. I'm not going any further. As we are running short of time, we'll take few questions from the participants. Okay, I could already see 1, 2, 3, 4, 5. Okay. Yeah.
So I just wanted to ask, there are, sorry, my name is Parvati. I'm from Kerala. So my question is around, there has been a lot of misinformation when it comes to health, like medicine intake and all, that has been spreading even with the advent of social media and other things. So how has it been a barrier when it comes to accessing or like building that awareness within the community? With Kerala having so much of health initiative, has it been in any way a barrier in like all these programs that are being implemented? Yeah, thank you.
Maybe take 2, 3 questions and then, yeah, okay.
Yes, hello, ma'am. Yeah, it was a great presentation to listening to you, JC, ma'am. I am Guru Saravanan from Institute of Grassroots Governance. My question is related to, from our experience, I mean, in Chennai, access to emergency contraceptive tablets, and then in few primary health centers where the nurses or doctors, some sort of moral policing would be there. So I wanted to hear your opinion, what is the status of that in Kerala, especially on urban sites? And also similar to my friend who asked the question, there are a lot of innovative efforts that we notice, especially the health plan. There are areas where due to water pollution, there are a lot of diseases, sort of like a mapping of the diseases that is emerging because of this urban, pollution, and stuff like that. So from your experience, have you found any sort of bottom-up development plans? Yeah.
Hello, my name is Aruna Bhattacharya. Thank you for the presentations, both of you. I work mainly around health systems, and I'm trained as a medical anthropologist. So more than questions, I have comments. So when we talk about, and also because it's coming from the context of listening to all the sessions last 4 days. So maybe it's a problematizing, I'm problematizing it. When we talk about health and health systems and the kind of descriptions or the way we discuss it, are we discussing about a success system or a disease system or a health system? Because oftentimes, like for example, this finance, you talked about now that we have the 16th finance thing come up, and also talking about NUHM, NRHM, all the details that we know from rural to urban, and talking about local, like how we also health is a state subject. Sometimes how the most of our national policies are implemented as a state, at its own whims and fancies, with their own whims and fancies. So the question is, shall we tie or discuss health or discussions around health when it is about a disease, or when we are talking about migration, when we're talking about labor, when we're talking about housing, or for that matter, drawing up, master plans for urban areas? Because if we are talking about future of urban or urban, sustainable urban, we cannot put health in a silos. We have to tie it down as an intersection, maybe from the beginning, before even health become unhealth. So it is more of a reflective question / comment. And also because we have a lot of youngsters among us, so we should not talk about health when we only see TB, HIV, or problems that are more of a crisis, and we are then not preventing, we are operating out of a reactive measure. Thank you.
One more, okay, there are two more questions.
Yeah, thank you. I'm Javed from University of Kashmir. Just to further what the medical anthropologist said, because the way bureaucracy is functioning, particularly in the North India, and especially in Jammu and Kashmir. Yeah, so the way bureaucracy is functioning, I mean, they are turning to be the health experts everywhere, though even they do not have the proper appropriate backgrounds to plan health policies. So unfortunately, the over bureaucratization of health systems and services is also one of the crucial and critical issues. Thank you.
So since we have quite a few more questions, maybe would you like to answer this round? Then we do one more round. That's fine.
So I just wanted to ask about, like, there is so many kind of misinformation when it comes to medicine use, or even what kind of medicine we use for treatment. So how does that affect in building awareness about initiatives?
Yeah. Yeah, again, there are a lot of misinformation, and in Kerala is one of these states we have maximum, what do you say, health, medical sale happening, and the maximum medicines sold out. So people are, to a certain extent, people are aware, but at the same time, they may not have the proper awareness also. That may be the thing. So there should be, even though literacy is there, the health literacy is something different, I think. So again, we have to start from the communities. We should, that is why I, relating to his question as well, he was asking about the availability of emergency pills. Again, the Kerala situation is that is available in all the medical store, in the medical pharmacies, it's available. The people will be availing from the pharmacies, and nobody is bothered of that. Also cannot be used for a long time. People are not bothered of the side effects and things like that, and that is happening from since the privatization is much promoted. It is there. So people are accessing, but the government institutions is, again, one neglected area is related to sexual health. So that is lacking in Kerala also, much lack in that area. We are not giving proper health education, or even though we have all these Kishori, what is it, Shakti Yojana and Karyakram. There are many programs for adolescent girls and adolescent people, but these are also implemented in the wider context of moral policing and that kind of thing. So these areas we have to sort out. That is why I was bringing this issue of Jagrata Samidhis also. In principle, we have the Jagrata Samidhis catering to the need of the women's health. But these things are not taken care of. That is very important, I think. But your question also, how the bureaucracy and dealing with the, so in Kerala, what he was talking about the KILA, that's Kerala Institute of Administration, Local Administration Training. They are organizing a lot of training, and initial periods, it was, I think, very good. The trainings were conducted. I don't know how it is now. Trainings were conducted along with there will be bureaucrats will be there, then experts will be there. Administrators will be there. We have to, and this local governance is one area we can bring all these people together. And the training should be together, and they should be enlightened on how to make the plans for the future, how to take the opinions from the community, or how to participate people in that, the whole process. It's an iterative process. Again, you have to go back to the people, again include the people's representatives also in all these. That is, it should be, ideally it should be. And initially, I think in Kerala, all these processes were happening very good. I don't know how far it is now. But the same thing, the people's awareness, it is from both sides, I will tell. Another very important thing I want to cite here is related to abortions. Again, Kerala, highly literate, but here even the doctors are hesitant to do abortions, even though the law is there. And people are also not ready to talk about it. And we get so many private calls, but when it comes to the public statement, no organizations, even we have all these neighborhood groups and very strong women's organizations, but no, even women's organizations are not demanding it. So what I'm telling is that demand should come from the people also. People have to, in democracy, the plans and things will happen only if there is a demand and participation of the people. So people are also hesitant, simply criticizing the politicians, of no use. We have to actively participate in the whole planning and implementation process from the grassroots level to the beginning. And nowadays we are struggling for representation in the assembly and parliament. As that participation is very low in Kerala. Even though we are highly educated, the higher education is also more than 96% up to 100%. But when it comes to the authoritative bodies like assembly, the policy making or law making bodies, very few. Kerala is much behind than any other states also. So all these levels we have to get involved and participate.
Actually, I just want to respond to one comment on bureaucratization versus experts. So when you say experts, I don't exactly mean whether you mean only doctors or, see, as it is, the health sector has got a lot of experts from various other social science arena. Like even in an established institution like NHS, there are economists and social scientists working in NHS. So do you call them also experts? So in that way, if you expand that gamut of experts into all these various different disciplines, then it makes sense. But as of now, very often what is happening is the bureaucrat himself expands his interest into some of these areas. But I personally know some bureaucrats, I don't want to mention names. They're very well-known names. They have learned about health. I mean, former chief secretary of Telangana. I was working in Hyderabad. I mean, I was heading a institute on health. He asked me, which book should I read for public health? So I suggested him something. I'm a social science person. That kind of humility also is there in some of these bureaucrats. But that sort of thing is not there in everyone. There are so many other people whom we can think about. So we cannot, brand the entire bureaucracy in that manner, because very often a lot of innovative thinking has come from the bureaucracy as well. Like I was mentioning about how the bureaucracy changed the National Urban Health Mission, which would have been originally an insurance model, to a public health-based model. That is the action of the bureaucracy. There was definitely some bureaucrat over there, I suspect some names, who has changed it from insurance model to public health model. So you cannot brand the entire bureaucracy in that. And experts, when you say, don't think that only the doctors are experts. It is a very wide arena of people who are in health. I worked with one of the doyens of public health in India called N.H. Chandia, who was a plastic surgeon. He used to say, just like Winston Churchill said, the war cannot be left to the generals. He is a public health, plastic surgeon who branched out into community medicine and then constituted an interdisciplinary institute called Foundation for Research in Community Health. So he is saying, just like that, health also cannot be handled only by the left only through the doctors. So when you say experts, it should be a broader arena of various experts. That sort of an understanding has to be there.
Yeah,
And bureaucracy very often was playing that role.
Actually missed your question also, and it should not be reduced to curative part only, as you told. It is correct. Even NHM is a product of this kind of discussions which happened all over India. We are much confined to curative aspects. Even I am from community medicine. The definition of health is it is not only curative, but we have to include health promotive and preventive and palliative. All these aspects are, that is the comprehensive approach of health. So there was a lot of discussions regarding that, and that is how this NHM happened, looking into all these areas. And Kerala, we had the discussion plans for the Vision 31 for health and other areas also very recently, 2-3 months back. And in the health session, it was envisaged like well-being. It is not just treatment of diseases. Even the concept of health was defined as well-being. So these things are happening in certain levels.
One, two, yeah, we go to you, then there. So many questions.
Thank you for the presentation. I'm Neetu. I just want to share a concern, not really a question. We were talking about how the public health system in Kerala has improved recently, but still we know that it's really insufficient to accommodate the whole population in the state. That is very evident when we go to the private hospitals. Those hospitals are really crowded if we go there and all. And then recently, we know that some of the American investment firms has come to Kerala and made agreements with the private hospitals in the state. And then it's heard that the insurance system is going to be implemented in those hospitals and all those concerns regarding that. I just wanted to ask whether the government of Kerala has acknowledged this as a challenge, whether assessed how it is going to affect the public health in the state, and then whether any steps to tackle the situation or any kind of discussion at least happened in this regard. Thank you.
Good evening. So even in this time and era, yeah, my name is Advaita and I'm an undergraduate student. Also wonderful presentation. Even in this time and era, our country is allotting only like 2%, lesser than 2% of our GDP in the healthcare. So, I've always wondered if this financial constraint that we have is, indirectly affecting the people who are seeking for better health. So as doctors, if you could change something or if you could bring about a policy decision where you want to focus on a specific area, where would you, focus on mostly? Thank you.
Good evening. My name is Vidika. I'm a mental health researcher based out of New Delhi. My question is about the intersection of public health infrastructure as it exists now and the growing demands for mental health care. And I wanted to ask you, in your opinion, as people who've been working in this field for a long time, considering that here we're talking about reimagining citizenship, so taking an active role in changing our urban landscapes around us and in shaping those urban landscapes around us, I was wondering what your opinion or what you think what the future of public health care, particularly population mental health care, looks like, and what we as active citizens can do to improve those situations, particularly since, as it's been mentioned many times here, the population in urban areas in India is only going to grow. The demands are only going to grow. Climate change issues are only going to grow. The number of the amount of diversity is only going to increase. So how do you, what do you envision for the future there?
I would just like to address the question on privatization, which was asked by one of the participants. Actually, the growth of private sector in Kerala is happening on a very big scale. In fact, it is happening, Kottayam is relatively insulated from it, I would say. The big hub of privatization is Changanasheri up to Adu. There are about 10 big hospitals, many of them run by even church institutions. You don't, when I say church institutions, don't think that it is charitable institution or anything. They are all run as private hospitals only. And all these hospitals have got all multi-specialities. They have got all the various highest technological equipments which are necessary, to the extent that it is very likely that there will be a lot of unnecessary tests which are conducted just to pay the running costs of even these equipments. And there will be a lot of false positives also, which they will arrive at. I mean, where there is no need for an angioplasty, they will do an angioplasty. In fact, I escaped one of those because I went for a re-examination in an institution in Kottayam. That's why I'm saying Kottayam is relatively insulated. Because Changanasheri, Tiruvalla, there are so many. Tiruvalla has got Pushpagiri. Tiruvalla has got Believers Hospital. Tiruvalla has got Tiruvalla Medical Mission. And there is Changanasheri, there is this Chettipuda Hospital. And coming to Adur, you have got Childhood Hospital, Childhood Medical College, and there is Lifeline Hospital, which is operating even in Gulf. And there are so many others. In Chenganur, you have got KM Hospital. And Chenganur itself, there are other hospitals. So there are about 10 very big hospitals in these various places where getting reasonably good medical care, good and necessary medical care has become really difficult. So this is a situation which we are going through. And as you rightly said, many of these hospitals, these ones not, there are some others like Baby Memorial in Calicut and many others, which are appropriated by Blackstone and various other American corporations, which is inflating the cost. And without a proper insurance in your hand, you cannot walk into these institutions. This is all the more the reason as to why the public health hospitals, government hospitals have to be strengthened, why people have to feel like even the upper class should feel like going there and taking medical care. Now, when I say this, I don't mean to say that the public hospitals are all problematic or something, because now in the media you hear a lot of stories. The other side is that even some of the very rare surgeries, complicated surgeries, which are normally done in big private hospitals in other states, are conducted in the public hospitals in Kerala. So there may be some mishaps happening. I do not deny that. So that is one aspect of it. The other aspect is that I haven't gone into that literature in depth, but I know that in many of the European cities, they have got something called technology capping, which means you have a certain equipment in one hospital, and within the radius of that hospital, they will not allow other hospitals to procure this high cost equipment in order just to make sure that unnecessary tests are not done. So this technology capping is something which health experts in Kerala need to be studying. Recently, another well-known lady, again name, I don't divulge. She is also a very well-known person. She was consulting with me before delivering a lecture here. So I gave this suggestion. She said she has carried it to the policy people. So these are some of them, because she is not from Kerala. She is from outside Kerala, and a nationally known person. But all said and done, Kerala has to go in for this technology capping. Otherwise, people will end up being tested unnecessarily, being conducted procedures unnecessarily. Lots of this is happening already. This is the other questions I don't want to.
This discussion about corporatization and all these things are happening in Kerala for so many years. I'm in the field from 80s, I'm telling you. So we had so many policy discussions, all these things. And what happened in the 90s is that we all know that the globalization and the neoliberal policies, that will be affecting, of course, our state also. And the health budgeting, she was talking about it, and how much is the expenditure by our nation. It is less than 1%, I think, nowadays. Ideally, there should be at least 5% of the GDP should be spent. So with these constraints, in Kerala, government is trying to do something. That is the only thing I can say, because we have these family health centers. At least some of the PSCs are upgraded to family health centers, and we have the Ardhram mission. Ardhram mission is trying to strengthen the middle level hospitals also, like the taluk hospitals, district hospitals, etc. Many of the facilities are available. Many of the things are available. That is, I think we have a lot of budget constraints and limitations. Even then, trying to strengthen the government institutions. That is one thing we can do. It is happening to a certain extent. But what about people? Are people accessing this? Because people have the choice. People have the choice to go to anywhere. But what is our culture? Then she was talking about the crowding also, overcrowding in the private institutions. What about government institutions? You go to any hospitals, PHCs, Taluk hospital, district hospital, private hospitals, everywhere it is crowded. You go to any country, UK or any European country, you cannot access health like this. Nowhere in world people can access healthcare like Kerala, I bet you. Even COVID time, any time, and we have to change the culture of people also. That's what I want to tell. And referral system. Ideally, it is a referral system. What does it mean? Referral system means first you have to go to a PHC, then if refer to a higher level, and then to the tertiary institutions. Is it happening now? Because the politicians also won't allow it. The politicians want votes from the people, and people will be demanding to their MLA. You call the health authority, and everybody wants to go everywhere. So there, it is not strengthened. And another is Clinical Establishment Act that has been brought in the 2015 or sometime, not yet able to get implement properly. So in according to Clinical Establishment Act, all the private institutions have to demonstrate all the cost of all procedures and everything. But again, not able to implement. One thing is no demand from the people. Are people included in that? Where is a social audit? If you have to strengthen the public health system, there should be social audit. And people are not willing for that. Now, I'm not blaming people, but everything should come. There is a civic responsibility also. And everybody want all quality care. People think that quality care is only from the private institutions. These are some of the problems specific to Kerala, not in general. And mental health, of course, mental health also should be a concern. She was in Kerala, mental health is very poor, even though we have achieved much in the other physical health aspects. Mental health indicators show that the suicide rate is very high, depression, anxiety, all these high. There should be interdisciplinary approach to all these things. I agree with that.
Thank you, Dr. Alex and Dr. Sridevi. May I now request, Mr. Joseph Mathai to give a token of appreciation to Dr. Alex and Dr. Sridevi.
The tea is ready and we are a little late, so